I would be talking about a subject which is a bit transdisciplinary or interdisciplinary. It is directed to neurologists and to speech language pathologists. Rehabilitation of people with aphasia. And it's a daunting task. There are many challenges because of treatment gap. The word treatment gap I heard for the first time in epileptology, that treatment for epilepsy is available but is not reaching the patients. The treatment gap for aphasia is much more, and there are many reasons. I will not go into the details. Another reason for challenges in aphasia rehabilitation are pertaining to the nature of the problem, the beast itself. There are difficulties in diagnosis, in classification, in profiling, and therapeutic research with the help of randomized controlled trials about the efficacy of therapies for aphasia is beset because of heterogeneity and confounding variables. So there are so many challenges. As a neurologist, we must know that post-stroke aphasia persists as a long-term disability in about 25% of survivors. All of you know how common is a stroke. And if a stroke is that common, about 1/4 of them will have aphasia. So it's a big problem. A general neurologist is very busy and aphasia assessment is very lengthy. So we are often using non-standardized and non-validated ad hoc assessments, which is not an ideal situation. Ideally, it should be with the help of well-established standardized batteries. So there are many more challenges. Now coming to the definition of rehabilitation. It means many types of cares which can help one to get back or to keep or to improve the abilities which are needed in daily life at many situations for communication purpose. The person after rehabilitation should be able to speak, should be able to listen and understand, participate in conversation, reading, writing, mathematics, associated cognitive abilities. Everything should be as normal as possible because of our efforts of rehabilitation. And the steps in the assessment rehabilitation are assessment, goal setting, therapies for restoration of abilities, communication partner training, aphasia friendly social environment. And once we think that we have reached the limit of restoration, so once we think, the neurologist or the speech language pathologist, that we have reached the limits of restoration, even then our role as a physician or a clinician continues, and we have to counsel the patient and families about adaptation, about means of assistive and augmentative devices, about acceptance and coping with the new normal and eternal striving. A word here that don't carry an impression that there is a sort of therapeutic window for the therapy. Oh, you have come late, if you would have come much earlier. There is nothing like that. And the patients with aphasia continue to improve many years. In many patients who have reached the plateau phase, then we thought that whatever improvement had to occur in the initial 6 months to 1 year, and now no more improvement. If they are administered appropriate speech language therapy and other interventions, they also improve. The assessments of aphasia are very important because all your efforts of rehabilitation will be guided by your assessment, and that includes severity of aphasia, clinical profile and syndrome, impairment based profile, and many other aspects of related neurological deficits including cognitive deficits. Based on these assessments, we will do the measures for rehabilitation. Today is not the time to go for a full clinical examination for aphasia, but just to recapitulate, a proper assessment includes auditory comprehension, articulation, fluency of speech, repetition, naming, reading and writing. And a screening test can be administered in about 10 minutes. Slightly detailed bedside assessment can be done in about half an hour. But a full assessment will require 1 to 2 hours, which cannot be done in one setting, and that is rarely done by a neurologist but usually done by a speech language pathologist. That is also necessary. We should also test the related higher mental functions, because aphasia is not an exclusively language related problem. Language is one of the cognitive functions, and it is not at all surprising that other cognitive functions are also affected. We have traditionally been taught to make a diagnosis of Broca, Wernicke, transcortical, conduction, anemic, global aphasia syndromes. But in the last 1 to 2 decades, aphasia syndromes are being considered as outdated. The syndromic classifications have been helpful as a shorthand summary of patients' language disorder. However, syndromes have lost their theoretical and practical relevance. Newer classifications based on neurolinguistics and cognitive neuropsychology, they require modification in the methods of clinical examination, and we must adopt a deficit-based approach instead of syndrome-based one. I give analogy with epileptology. When instead of the old classification of epilepsy syndromes and types of seizures, we are paying more emphasis to semiology. Similarly, in aphasiology, we pay more importance to semiology. Included in the assessment are functional communication level, quality of life assessment, goal setting for the degree of rehabilitation, and recognizing how many factors can affect our goal setting. The rehabilitation for persons with aphasia is getting better and better because of improving theoretical understanding of the brain damage and the recovery in neurobiological terms. The potential avenues for repair, replacement, and enhancement are being studied, and now we know the difference that there can be restoration of the function, there can be compensation of the function, and there can be reorganization of neural circuits at the level of neural, at the level of cognitive, and at the level of behavioral assessments. New neurons may not have mitosis, but some degree of neurogenesis is possible in brain. Of course, a lot of synaptogenesis is possible, and lot of changes in the neural networks are possible. All this understanding of neural plasticity because of speech language therapy is now evidence based from the functional MRI studies, in which they show that as a result of a particular regime of speech therapy, there were changes in the functional MRI networking of the brain before and after therapy, or between those who received the therapy and those who did not receive the therapy. The better theoretical understanding apart from neuroplasticity is also occurring at the level of neurolinguistics, cognitive neuropsychology, and that is leading to better tools to assess aphasia, and a potential theory of aphasia and potential new methods of speech therapy, the behavioral therapy, have evolved in last 2 decades. The therapeutic rehabilitation for aphasia is mainly into 3 parts: speech therapy, pharmacotherapy, and non-invasive brain stimulation, out of which the pharmacotherapy and NIBS are biological methods, while the speech therapy is behavioral method, and that itself is of 2 types: holistic and impairment based. Holistic means you do not pay attention to the impairment. You say, let the person go into life participation, the holistic method. And in impairment based method, we do the detailed profiling, and based on the areas of deficit, we administer the intervention. The evidence that the therapy works has come from recent systemic reviews and meta-analysis. And main thing is the behavioral approach, which are language-based drills administered by speech-language pathologists through face-to-face interaction between a patient and a clinician. So I have already told about the impairment-based therapies. The other holistic method is also called life participation approach. As they say, if you throw a baby in water, he or she will start swimming. So similarly, if you throw a person with aphasia in community, let her participate in activities as much as possible, which unfortunately does not happen in real life. That life participation will help. And the impairment based therapy and the life participation holistic approach, they are not mutually exclusive of each other, they are complementary to each other. A word about pharmacotherapy. Many medicines have been studied in the treatment of aphasia. The results have not been very impressive till now, but the prospects are improving. Pharmacological augmentation of speech therapy is more robust and reliable with either stimulants or cholinesterase inhibitors or dopamine agonists or serotonin reuptake inhibitors. And it has been documented that while pharmacotherapy alone may not work, speech therapy alone does work, and speech therapy in combination with pharmacotherapy works even better. That evidence has come up. A word about non-invasive brain stimulation, which is done by repetitive transcranial magnetic stimulation and transcranial direct current stimulation. They have been employed in chronic aphasia in last 2 decades. Many trials, randomized trials, and many systemic analysis have been done, and there is evidence that they do work. And how do they work? When you apply the magnet or current on one or other hemisphere, right or left, you can do either stimulation under the hemisphere or you can inhibit that hemisphere. They are not very precise. Their spatial resolution is not good. They will stimulate or inhibit a large chunk of cerebral hemisphere on one side. Now, whether you give the stimulation on left hemisphere or right hemisphere, when you give stimulation on the left hemisphere, which is commonly the site of lesion for aphasia, the dominant hemisphere, you give stimulation through the cathodal current so that the perilesional cortex gets enhanced function. When you give involve the right hemisphere, the non-dominant hemisphere, you give inhibitory, the anodal current. Why? Because the right hemisphere overactivity has been documented to be counterproductive in the recovery of aphasia. So you want to suppress the right hemisphere. Normally we used to think that when a person is improving from aphasia, the non-dominant hemisphere must be pitching in to improve the function, but unfortunately it is not so. The overstimulation of right hemisphere may be inhibitory. So this is the transcranial magnetic stimulation, and this is the transcranial direct current stimulation. And a few words about computers in speech therapy. In rehabilitation department, as well as with or without speech therapy, they can be used at home. There is a now large expanding collection of practical material in multiple domains, and computers can be in sync with teletherapy. The benefits of new technology are manifold. We can use smartphones, tablets, many mobile apps, many interactive softwares, teleassessment, online accessibility. They are automated, they provide recording, they provide storage, they provide retrieval, they help you in analysis. So many things can be done with the help of machines. You can have a variety of stimuli. In traditional speech therapy, we used to have cards and pictures and images. In the case of computers, there is no limit how many types of stimuli you can use. You can go on editing them, you can go on changing them. There are voice to text, text to voice, image to text voice, machine translation, transliteration. So many things are possible with the help of computers. So many things have come up, commercial software and hardwares, online and offline, which can help the person talk. Virtual speech therapy. So there is a virtual speech therapist in the form of an avatar on the screen, and it can be done with the help of teletherapy, in which a real speech therapist is talking to a patient, or vice versa. So teletherapy is helpful. Social phobia is a big problem in patients with aphasia. The depression, the anxiety, the apathy, the lack of interest, and being cut off from the friends and family is a real problem for patients with aphasia. And there is a recurring fear of going into social situations, and we have to fight against them. And here comes the role of social approaches. Again, I will not go into big details, but what is more important is to understand that for every disease, not only aphasia, but more so for aphasia, there are two models of medical intervention. One model is known as biological model, and we the medical doctors are mainly immersed, mainly thinking, mainly reading, mainly working on biological model. But there is something called social model, and the WHO pays a lot of importance to social model of a disease. That means the biological factors are important, but equally or probably more important are the social factors. The milieu, the environment, the type of family support, the type of personality, all these things play a great role in rehabilitation of people from aphasia, or for that matter any disease. And then here comes the role of a forgotten cog in the wheel of care. Of course, aphasia rehabilitation is a multidisciplinary work. Occupation therapist, physiotherapist, clinical neuropsychologist, the physician, neurologist, speech language pathologist. But who is forgotten? The carer, the significant other, the communication partner, the family member, and they have many roles. They help in assessing the burden, emotions, knowledge, attitude. They are a person who can speak for a person with aphasia. They are a link with the clinician. They are an aid and assistant in the therapy. They are become therapist herself. They are participants in research. They can work as advocate. They are a leader in patient support groups, and they are a narrator or a storyteller. And for that purpose, we have developed a big collection of home-based exercises for persons with aphasia as a part of speech language therapy. And we are in the process of developing a digital app of all these exercises, which would be operable on a tablet or a smartphone, so that the greatest barrier in the therapy of speech language is that it is time consuming, it is intensive, patients are not able to afford, they have to come every day to the therapist. It requires a lot of effort. And it has been shown in the recent randomized trials that for speech language therapy to be effective, it has to be administered intensively. Now, what do you mean by intensive? Suppose a patient was given 60 hours of therapy in 6 months, and he improved to some degree. The same 60 hours of therapy, if it is given in 1 month, that means imagine how many hours per week. That is more effective than the same duration of therapy spread over 6 months, and same duration of therapy is spread over a lesser period of time. Highly dense therapy in randomized control trials has been proven to be better than a same duration of therapy spread over a longer period of time. And for intensive therapy to occur, you need help of family members with the help of home-based exercises and with the help of teletherapy. Another concept which is emerging nowadays is communication partner training. Who is communication partner? Anybody who comes into contact, who happens to be talking to a person with aphasia, is a communication partner. Suppose you go to a foreign country and you do not know the language. How do you communicate? If you have some interpreter, then he or she may help. The interpreter may not be very proficient. She is a poor interpreter, but some degree of work can be done. Now imagine a person with aphasia is a speaker of a foreign language, and you need an interpreter. Who can be the interpreter? The communication partner for the larger world, for the aphasic patient to talk, and for which we have developed a communication partner training syllabus. It is a 6-hour course which is given in 2 sessions of 3 hours each, and we have classes for healthcare workers, they are also communication partner, and we have classes for caregivers or family members of persons with aphasia. So 3 hours on one, and after a gap of 2 weeks another 3-hour communication partner training syllabus, and that helps in improving the quality of life. You are not giving any therapy. Therapy is a different thing, but you are improving the environment around the person, and then with that we train them to become better advocates for supporting the participation of persons with aphasia. We need lot of advocacy for people with aphasia. We want to encourage environmental adaptations to promote communication, to alter the information complexity, to prepare for the management of emergencies, and to provide accessible information regarding the services. We in India often face constraint. Our resources are limited. So how can we help with limited resources? The options are group therapy, family members as therapists. We the physicians should also play a role of therapist. This is happening in the case of physiotherapy. It should happen in the case of speech therapy also. There are many neurologists who go and specialize in what is known as restorative neurology, and they become part of physical therapy team. Same thing should happen with clinicians. They should become as therapists to some extent. Of course, computerized methods and teletherapy will help. Unfortunately, there is a dearth of felt need for therapy and rehab amongst people with aphasia and caregivers and therapists. This is a sad fact of Indian society, Indian culture. The degree of demand, the degree of desire from the people suffering with aphasia, which is seen in Western countries, is not seen in Indian circumstances because of good family support in our life, and patients do not have to go alone in the society. In Western countries with nuclear families or isolated people, they want to improve because they have to live with their aphasia. Because in our families, we do a lot of seva for our family member, the service for our family member. They don't feel the need for speech therapy. That's why they are not coming for intensive language action therapy. So that's a problem. So in conclusion, I would say that rehabilitation of people with aphasia and related disorders of speech and communication is a daunting imperative for society in general and various stakeholders in particular. The burden at the level of community, family and individual is very large. The problem is relatively neglected in comparison to many other neurological diseases when we talk in terms of overall incidence, when we talk in terms of overall prevalence, when we talk in terms of daily disability adjusted life years. Aphasia is a big community burden, yet it is relatively neglected, and the irony is stark because the evidence-based behavioral and medical interventions are available, and yet the treatment gap is huge. The nature of the challenge is itself difficult. There are problems in diagnosis, classification and design of randomized controlled trials. Future progress will depend upon better theoretical understanding of neuroplasticity, standardized and validated objective and subjective assessments in multiple languages and cultures, multi-pronged team-based intensive interventions and combination of medical and social approaches. Short and long-term goals of aphasia rehabilitation should be SMART, and SMART is an acronym which stands for specific, measurable, meaningful, achievable, realistic and time-bound. An important but often forgotten cog in the wheel of the care is caregiver or the significant other. Training of communication partner can go a long way in rehabilitation, and when therapy and rehabilitation reaches its limit, the clinician should become counselor about acceptance. However, the future looks bright with strides in neurobiology and better leveraging of social factors through advocacy, awareness and life participation.